Top Bed Talk.
Tim Miller, who's been up here before. Tim is from Duke University, and he's going to be talking about perioperative blood pressure. Welcome, Tim, please.
Thank you, Desiree.
Tim, so I was in the group with you and a number of other people in the audience. I just want to touch on a second on that post-operative bit, which I think is probably all recognise where a lot of the potential harm is happening. We'll come back to the in the operating room bit in a moment, where there is a strong signal, but the signal is much stronger in the post-operative period. And as you quite rightly say, it's embarrassing, A, how little literature there is, and B, when there is literature, how little monitoring our patients are getting, including in the USA, which, I hate to draw these comparisons again. You're spending a huge amount of money on healthcare. Duke's a very shiny place. Surely you could be monitoring people on a more regular basis.
I agree. It's interesting. I think the perception is that we have a lot of money. We have a lot of money in healthcare in the States. We do. But the perception is that everyone will go to a high-level care environment, and that we have vast ICUs. We have 150 ICU patients in our hospital, but a 75-year-old will get a Whipple procedure and go to the floor, the ward, post-operatively. So we still send patients who have high-risk surgery to the post-operative wards with sometimes very infrequent monitoring. So it's not as if all patients go to intensive care at all. And I think I had the perception before I moved there, which is 12 years ago now, that would be the case, but it's not.
So I saw some data presented recently, and Guy Ludbrook and Bernard Riedel gave me permission to share it, that was gathered in Australia. And some of you in the room may have been part of this pilot study, where, as I understand it, and I'll use the example that I was shown from the Peter Mac in Melbourne, which is a cancer hospital. They reported the number of METS calls, and if I'm remembering this incorrectly, I do have the slides. Please, if you know about this better in the room, correct me. They looked at the number of METS calls for a longitudinal few hundred patients at the Peter Mac Cancer Hospital, adult patients having major surgery in Melbourne and Australia. And when they were waiting for the METS calls from the floor, there was about 5% of patients triggered a METS call, so about 1 in 20. They then did a longitudinal series, and I think they did it in 2 centres, but we're going to talk about the Peter Mac one, where they kept all those patients, all of them longitudinally, in recovery overnight and continuously monitored their blood pressure. And 1 in 3 to 1 in 4 people actually triggered a METS call. And on triggering that METS call, the commonest intervention was the administration of a bit of fluid, but more commonly a vasoactive agent, which you're not getting on the floor. And the results they presented were a great improvement in outcomes, and the savings overwhelmed the cost of that intervention. I think that's a really, really interesting. There's lots more work to be done in that, but I think that's a really, really interesting area, because our personal experience at UCLH is by really increasing the amount of outreach onto the floor, we haven't had as big a return on that investment as we'd anticipated. And that may be just because of the frequency of monitoring means we're still missing the point.
I agree. I think Dan Sessler's done similar work at the Cleveland Clinic, not looking at outcomes per se, but looking at continuous blood pressure, using the clear signs and then blinding everyone to what those measurements are, just to see how often we're missing hypotension. And we get back to the debate we were having with Denny the other day about, I forget the levels of care here, the level 1B?
Yes.
I think there's a huge unmet need for that care, including at our institution. I mean, we have some patients that stay in the POQI overnight, but just be able to have continuous blood pressure, little bit of background vasopressor as needed. It's very interesting. I think that's the first data we've ever seen showing that improves outcomes, which again is amazing, really, because I think intuitively we all think it probably does.
It's pilot data, and I think there's an intention to do a much bigger evaluation of this. Intuitively, we would think that's a good thing to do. The pushback is it's an expensive thing to do. The reality may be it's a cost-effective thing to do, and that's what I think we need to work out fairly quickly. Certainly the way I'd like to be looked after, I wouldn't like to be abandoned to the floor. I'd like to be monitored more continuously, and if I need a little bit of vasoactive agent rather than another few litres of fluid, I think that would be a nice thing to have. May I take back, Desiree, before we open up to some Slido questions, to one other point. The prize paper yesterday, the one that won, which was a large data set from the USA, has really moved us on with those observations from the Cleveland Clinic, I would suggest. So one of the discussion points was a lot of the debates about thresholds for blood pressure in association with harm. A lot of it comes from the Cleveland Clinic data set that you referred to. Fantastic work. No reason to doubt that it doesn't apply to a much broader audience, but I think led by Andy Shaw, a much bigger analysis is being done by hundreds of hospitals in North America now. And although there's a suggestion that the threshold of 75 is also in play, it seemed to be that it reinforced that there was harm associated with intraoperative hypotension. And you can read the abstract. That was the prize-winning abstract presented in the TRIPOM here yesterday.
Yeah, so I mean, a lot of the evidence so far is from one institution, so we need to replicate it, and it's great that that's occurring. And I think we're starting to get other data from Australasia as well. So I do think, this, like anything, you get one group that are starting to analyse their data, and then 3 or 4 years later you start getting other groups. And I think we're in that cycle at the moment, and so far it all seems to add up pointing to the same conclusion. But
we must be clear before we open the discussion, they're predominantly associations.
Yes.
The causation link is far from proven. Absolutely,
but I think, at least in my practice and what we agreed at the POQI, is that it is an association, but I think it's an association that it seems sensible based on this association to do everything you can to try and reduce the episodes of hypotension that occur. Not that previously I was liberal with hypotension, but I think there was this argument that it's, particularly with induction of anesthesia, that it's just an anesthesia-induced high flow, low pressure state, and that wasn't associated with harm. Yeah. And I think we have now evidence that is associated with harm. So it seems prudent to be more careful to try and avoid that.
I think Mike wants to...
Yeah, we'll go ahead and...
Optimise. So the original Optimise study, which I know was about goal-directed fluid therapy, one of the most striking findings from it, from my perspective, so they randomised to the group with fluids and some dopexamine, and the group that didn't have it. And in the group that didn't have it, 85% were receiving boluses of some kind of inotrope or pressor. And that, although it's not what the trial is about, that does seem to suggest that maybe just infusing a low-dose inotrope or pressor all the way through is going to make the ride a lot less rocky.
Yeah. And it's just interestingly, if you look at the Fedora study that you were involved with, which was a goal-directed therapy study, labelled as a goal-directed therapy study, it's actually, and the IMPRESS study is labelled as a blood pressure study. If you look at the two studies, they're actually basically pretty similar. You optimise fluids first, and then if they're still hypotensive, you start a vasopressor. So they're labelled as completely different studies, but the same approach. And again, in Fedora, a significant number of patients needed a vasopressor infusion. I can't remember the exact percent.
25% had an adequate index and a MAP below 65, and that was the trigger to start a vasopressor infusion, and that was about a quarter of the patients. Needing an inotrope to get an index above 2.5 litres per minute was very rare. So the common intervention is a vasopressor after the best you can do to try and get volume and flow right.
Top Med Talk.
Nick Majerison here. Thanks for listening to Top Med Talk. Now, before we let you go, it's important that we remind you to subscribe to Top Med Talk. That way you'll never, ever miss another episode. Also, if we could encourage you to join us on social media, Twitter, Facebook, LinkedIn, YouTube, pretty much every single social media platform, we're there. Join us. And finally, check out topmedtalk.com. If you go to our website, you can subscribe to email updates. That way we can always tell you where we're going to be, what we're going to be doing, and how you can join us. topmedtalk.com, and click on the section marked email updates. Finally, Top Med Talk is proud to act as the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about them as well. ebpom.org is their website. That's ebpom.org. And if you go to ebpom.org/meetings, you can find out about some of the wonderful meetings that we attend and cover across the year here on Top Med Talk. That's ebpom.org/meetings.